Good evening, everybody. It's 7 o'clock. Oh, blimey. It's 7 o'clock, so I'm going to try making a start. Welcome to tonight's Health, Adult Social Services Standing Scrutiny Panel meeting. I'm Councillor Daniel Crawford. I need to let you all know this is obviously a hybrid meeting. We have colleagues in the chamber, and it's great to see you all. We have colleagues online. It's also good to see you all. Can I ask anyone who's online if you could mute? Because otherwise it makes it very difficult for me to run the meeting. So there is someone who's come off mute. It might be Roy, actually. Sorry, Roy. If you could mute, that would be helpful. We are quorate, so I am going to begin with our apologies for absence. I have apology absence from Councillor Ben Wesson, who is unwell, and we send him our best wishes. Have we got any other apologies for absence? No. Excellent. Urgent matters. There are no urgent matters, but I did want to draw attention with the panel's permission. During the last month, Ealing sadly lost Judy Breens, who was a member of the Ealing Save Our Hospitals campaign, and also an attendee in a public capacity of these meetings. Her funeral was yesterday afternoon, and I did just want to ask the panel if we could note her sad passing and send our condolences to her family. She will be sorely missed. So with that being done, there are no urgent matters. There are no matters to be considered in private, and I've skipped over probably the most important item, which is declarations of interest. I need to ask colleagues for declarations of interest. I'm going to start with Councillor Matarza. Yeah.
Thank you, Chair. I just declare my interest that I am a general practitioner and serving within the Ealing Borough.
And I'm going to take Councillor Conti's normal declaration of interest, but he's not serving within Ealing Borough unless it's changed since Mr. Cook. Yeah.
I'm a member of Health Watch Committee.
Yes, and that's pertinent to one of our items tonight, but not prejudicial. I'm going to ask colleagues online if they've got any declarations of interest, but I don't think there are any. And in that case, I'm looking to, there are no indications. I'm going to move on. The minutes of our last meeting, which was a long time ago, on the 30th of November. Are there any comments for accuracy or otherwise about the minutes? Come on, Alan, I know you want to. Yeah.
Thank you, Chair. We received yesterday a copy of some information from London North West about the number of people that are actually admitted from A&E to the ward. There seems to be a discrepancy between the data that they provided and the data that's actually published by NHS. We were told there were something in the region, 40,000 patients were admitted. And in fact, the figure from statistics show that there were 71,716, a difference of 31,600. So could we please have some clarification from London North West as to where they get their figures from, please?
I think we're going to need to follow that up in writing because it's something that's been provided to us. I'm going to ask colleagues if they could mute. I think is it Roy? I'm not sure who it is, but it's rather disturbing. If we could mute, thank you. That'd be great. Yeah, so this is information that's been provided to us. I spotted that there were some things that didn't sound right, but you've crystallized it very well there. So I think what we'll do, we'll undertake to write to the NHS to find out what is the true figure and then see if we can get something. Yeah, that'd be lovely. Yeah, thank you. But on the actual substantive minutes, are we happy to take those as a true and correct record of our last meeting? Lovely. Since no one is indicating dissent, that's how I like it. Right. Our first item this evening is to discuss the Learning Disability Commissioning Strategy. We've been wanting to do this for some time. It's a very important document, and it's also very important that the voices and views of our disabled residents are heard, and far too often we don't hear from them. So Kerry Stevens, a regular at this panel, is here and is going to be presenting the strategy. But I do want to give a special welcome to Ali Khan Riley, who's the chair of the Ealing Power Group, but has been heavily involved in all of this. And we want to make certain that Ali Khan has the ability to communicate throughout what you want to about your lived experience, the experiences of your colleagues in the group, and anything you want to tell us. So it's entirely up to the two of you how you want to go through this. But at any point, Ali Khan, if you've got something you want to chip in on, just put your hand up or press your microphone on and go for it.
Thank you, Chair. And thank you for the welcome to Ali Chan, who's also the co-chair of the Learning Disability Partnership Board. So a key partner in terms of the development of the strategy. The Learning Disability Strategy is an integrated commissioning piece. So for the Council and NHS partners in Ealing, it's a 5-year plan for services for people with learning disabilities in the borough. The plan has been developed through extensive consultation and discussion with people who use services and their families. It's taken us a long time to get to a position where we're clear on the main areas of focus for the commissioning strategy. We're hoping this is now in a position that the Learning Disability Partnership Board for Ealing and our partners in the Power Group and Impact Theatre and a range of groups who join us at the Partnership Board will now develop a work plan to implement the changes to commissioning for people with learning disabilities in Ealing. Is that all right so far?
Yeah.
Good. Thank you, Ali Chan. So through our consultation process, lots of discussions with people with learning disabilities and getting to understand their lived experience of having a learning disability and living in Ealing. And we've come up with a number of priorities. And Chair, I'd just like us to take us through the priorities and then open up to questions if that's okay. So the priorities that came out from the discussions and the consultation are based on a statement that people with learning disabilities should have equal access and equal rights within the community in Ealing, and we think that's absolutely key point that we wanted to make at the start of the presentation. The first priority is meaningful lives, that people with learning disabilities should be socially connected with their friends, family, if they want to be romantically, and with their neighbours in their community. We think that community is absolutely key for people to be part of, don't we, Ella Chan? That people with learning disabilities should have a range of choice in terms of their daily activities in the borough, that they should have opportunities for paid work and opportunities for volunteering. Sorry, this is on page 31 in the pack, Chair. That a range of support and guidance to help them have access to voluntary work and paid jobs. People with learning disabilities will have homes that meet their needs within their community. We thought that was really important. And so services for people with learning disabilities would be of good quality to enable people to have choice and control, promote equalities, and pay staff at least the London living wage or the real living wage. So that was the first item that we've set forward as a priority. The second item is that people should feel safe and be supported to keep safe in the community. And Ella Chan and I were just discussing the impacts that travelling on public transport can have for people with learning disabilities and people feeling unsafe at night travelling around the borough. Did you want to come in on that?
I would, yeah.
Yeah, I'll use that one.
Okay. Transport is safe. If you're travelling on a bus at night, if the bus is full, let that one go and wait for the next one to come.
Thank you, Ella Chan. And it's good that sort of advice helps people feel safer in the community and to move around. And Ella Chan and I have been working with the Learning Disability Partnership Board to develop a information and training programme, not only for people with learning disabilities on how to feel safe to use public transport and to move around in the community, but also for other people in the community to understand the needs, which is really important. Another priority is around lifelong learning, supporting people with learning disabilities access the opportunities for lifelong learning, improving the health and well-being of people with learning disabilities. And we had a discussion about that earlier today, about the importance of annual health checks for people with learning disabilities, and the importance of those health checks being beneficial, and that the actions coming from the health checks are followed up, because we know that the life expectancy for people with learning disabilities is significantly lower than the rest of the population, and that often significant health issues are missed. Sorry, only two more to go. We talked about
so health, so the health for people, and they go to hospitals and they would go to their local GP practitioners and other places as well.
Do you find that it's okay for me to ask a question?
Yeah.
How do you find that experience yourself?
I get access to the GP and other places as well.
It's good, and they're asking the right questions.
They are, they're helping me. So
that's okay, Chair. That's your prerogative. Absolutely. So the last two areas that we were specifically referencing in the commissioning strategy is around the transition when young people with learning disabilities become adults at 18 through to 25 in terms of the educational legislation. It's really important that we support the young people and their families in terms of what it means to become an adult and to support them with all the changes in their lives. And that the last priority for the commissioning strategy will be around good networks for information and communication. And again, today at the Partnership Board, we've been talking about a closed social media platform for people with learning disabilities, where people can speak to their friends, get information, but be safe. Because we learn. Do you want to say anything about what we learned about Facebook?
We learned about Eugenie apps, UHubs. It's a new app that's developed by Ealing Mancap, and it's a new technology on a social media platform.
Is it safer because there are obviously issues with using? There are obviously issues with using social media that's widely available in terms of some of the abuse or things that might make people feel unsafe if they are using those, Instagram, Facebook, Twitter,
and TikTok as well.
Yeah. Oh, well, I'm not much of a dancer, but maybe you are, Alan. Good, good for you. But the key is that you feel safe and free to be able to express what you want to express, and that you can have those high quality conversations. Yeah.
Yeah.
Yeah. No. Good. Okay.
And it's a good way of sharing information with people with learning disabilities in the MenCap group, because it's a closed group. So information about transport we were talking about today, weren't we? So there's a range of that people can talk and chat with their friends, but also receive information.
And do we think that's an easier way to communicate information than writing things and sending people a letter? Do you think that your friends would access that more easily than like being written to in the post, or however we would normally do it?
Sending a letter to TfL.
Quite, yeah. Yeah, well, I'm going through that at the moment to renew my own freedom pass. It's not easy.
So what we find through discussions with the power group and through the partnership board is that often when the council and other organisations write to people with learning disabilities, they're not putting it into easy access formats for people. So, and because it's quite a young and happening group of people in the power group, they're all on social media. They've all got
Facebook,
and things. So this
Twitter, Instagram,
So it's just trying to create a safe space. So it was really opening up. There's lots of research in the papers here. There's lots of demographic data about future demands for services, etc. But these are the main areas and focuses of priority for the commissioning strategy. There's already developed a number of working groups through the Learning Disability Partnership Board and our commissioners, our joint commissioning team, for the implementation. So it is really bringing it here to the Scrutiny Committee to answer. Alichan and I will try and answer any questions that we can, but would propose that we bring back rolling updates on the action plans based on this commissioning strategy, Chair.
Yeah. Sounds sensible to me. I've just noticed that Nehar's name is in the introduction. I wondered if Nehar, did you want to say something in regards to this item? I don't want to leave you out.
Thank you. No, just to say that we have been very involved with the team who've been keeping us regularly updated on all of the activities that the team have been doing to put this strategy together. So it's really good to see it all come together and come to this committee. I know we've done a lot of work from a health perspective to train and make our GP practices and other areas understand the needs of our local learning disabilities population and what support and what they might need to do slightly differently to support our people with learning disabilities when they come in for an appointment or for their health check. So I'm really pleased to hear that it is making a difference.
It's great to have it here. Go on, Kerry.
Just to add that Nehar and NHS colleagues did some really groundbreaking work around inoculation resistance. I'm not sure if that's the right term, Nehar, for people with learning disabilities, which was spread across London. So I think we're ahead of the game in terms of our NHS engagement.
Vaccination hesitancy, essentially. Yeah. No, that's really important. Okay, I'm going to open it up to questions. So I've asked some. So I'll take Councillor Conti, then I'll come to you, Mr. Cook, and then we'll have a look online. And I've got Roy, I've got you. I'll come to you in due course. Councillor Conti.
Thank you. I had two questions. One on accommodation. So I think in the report it says about 77%, I think, were in settled accommodation. So, and that's comparatively quite good in terms of looking at other London boroughs. So it does sound quite low, the fact that almost a quarter of people with learning disabilities aren't in settled accommodation. I'm just wondering a bit more about why it seems like quite such a large number. And I guess in terms of, because obviously there's lots of different models in terms of the types of accommodation there are. And I saw that it was a small number of younger people in nursing home accommodation. I'm guessing that's more for their specific needs rather than because they couldn't be found to have any other accommodation. And just looking at how because over the course of someone's life, their needs obviously will change, and how that's reviewed over time to ensure that their continuing needs are met in terms of accommodation. And the other thing was just on learning disability health checks. The report talks about how there was some concern about the quality of that in terms of how, I can't remember the exact wording, but in terms of the health value or improvements that are coming out of the health checks. And I guess what steps being taken in terms of how to analyze what the issues are, how those can be improved, and then how that gets fed back into how the health checks are carried out in the future.
A lot there. So why don't we take those two individually and then move on? So Kerry, Alex, and Neha.
Should I go? You okay for me to go first, Neha? Alichan, you all right for me to speak?
Yeah, go ahead.
Thank you. So it's a really good point, Councillor Conte, in terms of settled accommodation. So settled accommodation means that people who are living independently or with their families in the community. We do perform well relative to other boroughs. However, I think there has to be a clear plan that's set out within this strategy to support more people live independently within the community where they've grown up and where they've got strong networks. So this is going to be an area of focus for us going forward. So I think it's an absolutely correct point. It's in line with the council's plan to support more people in their own homes. In terms of the nursing home accommodation, you're absolutely right. That will be people with more complex needs, often funded by the NHS rather than by the councils through CHC, but through Neha and I's joint commissioning arrangements, we procure those together and have oversight of them together. People's needs do change, and we know the physical needs of individuals, of all of us, but also people with learning disabilities will change as they get older. Regular reviews are a key part of the ensuring that the services meet an individual's needs as they change, and we'll come on to that later in the next paper and the quality assurance framework. So yeah, does that answer the first set of three, Councillor Conte? Did you want to come in?
Yeah. Councillor Conte has a good point. She spoke out really well about it and talked about the NHS and other things as well.
Thank you.
Thank you.
Thank you. Neha, did you want to come in, or are you happy?
Yeah, if I can just answer the other question about the quality of health checks. So I think it's a really, really valid point, and it's one of the things that we really want to do some detailed work on. As a first step is to hear from our local people with learning disabilities who are part of those conversations, but also making sure that everybody in our community that has a learning disability has an opportunity to have one of these health action plans and health checks. So the first stage, quite a few years ago, pre-COVID, we did some really detailed work with all of our practices to provide that training about the quality as well as how it should be done with the individual and their carer, possibly in certain circumstances. I think we do need to go around and do a bit of an audit to see the quality of health checks now, see the experience of people with learning disabilities, and reach out to them proactively and understand whether they found it useful or not, and then understand whether there is that quality gap. But we're constantly looking at those that quality improvement. There's always more that can be done better for this population, along with other stuff as well. But I think it's a key area that we know we want to just confirm, and there will be variation between practices. There will be some practices who are really good at doing some really good quality health checks and discussions with people with learning disabilities and explaining what these are and how this will help them and what individuals should do if there are problems. But there will be some practices that just need that little bit of extra support. So that is a constant process that we keep going around.
Thank you. There's a couple of things. I wonder if we are going to do an audit of those GP access and what those arrangements are like, whether there's a role for Health Watch in terms of helping with some of that, given the surveys that Health Watch has undertaken. I'm speculating here rather than Dan, go on, sorry.
We're definitely capable. We're already in the GP, so it'd be very easy us to engage. Happy to consult.
Yeah, I feel like it's something that the Power Group and the and our Learning Disability Partnership can almost design the questions, the kind of things that you want to ask.
Yeah.
You'd be up for that, and it would really help, I suppose, with NHS capacity if Healthwatch were able to use that access that you've already got. And, you know, potentially if we've got best practice that Nehal is speaking about in some practices that are doing it really well, how we share that, how we make that more widely available, you know. And then the other point, just on Councillor Conti made a point about accommodation right at the beginning. And we were talking about this in a different context earlier on. There's an opportunity for the local authority through its local plan and through what we're doing at the moment to be cognizant of the demand, because yes, we want people to live in their own homes. Now, not everybody is going to be able to stay in the same accommodation for the duration of their life. You know, things change. So we need to get better at procuring land and just co-designing the places where people want to live, because Councillor Conti is absolutely right. Not everybody who's of my age, for instance, will want to go straight into a nursing home. It's no one's idea of a good time. That's just something that's available for people to go into, isn't it? So, you know, I wonder if these are a couple of action points we can take away and add to the work of the groups that are the partnership board that's involved with this, but also, you know, actively using our members and Anachan and his colleagues to tell us what works, what doesn't work, and what you need in all of these areas. Because, you know, I'm cognizant of the fact that lots of people tell you what you need, but you're the ones who have that lived experience of seeing how, because everyone said, when we ask questions, not necessarily of Kerry, but of some other people, they tell us that everything's fine. And it only takes something to go wrong for us to learn that actually that might not have been the case. And we want to try and avoid that. So I think that'd be good. Now, Councillor Conley, I'll let you come back and then we'll move on.
It was just on if there's a review or audit going on of what, you know, or, I guess of how different practices operate. I guess just one of the things would be, because obviously with this particular patient cohort, continuity is really important. So, you know, if you get the same GP, a group of GPs who are seeing these patients for these reviews regularly, I think it definitely has more value. So I just wonder whether part of that is who's doing the reviews. You know, is it, you know, because I suspect most practices, it's probably a small group of patients. And is it the same GP that does those, you know, each year or every, you know, when they see them? And I think maybe that, I guess, would have more value. I guess the only other thing would be is that what, from personal experience, is one of the key things, obviously, getting blood tests, ECGs done in this patient group. And that can be really difficult because of fear, behavioral issues. And one of the things that often can be difficult is getting this group of patients to go through like desensitization programs. And I know that's a real, there's some patients I've got with learning disabilities who haven't had bloods for years and they've been on waiting lists for 18 months. I know it's a different borough, but to get those sort of programs to be able to try and facilitate that. And sometimes it's if we're thinking about the long-term health outcomes, knowing someone's cholesterol or knowing someone's blood sugar is so important, but can be really difficult to achieve. So I guess how those investigations being facilitated, ensuring that there is that support to get those done.
I think there's 2 points there, isn't there? The continuity of the same people being involved in the long-term care, which is difficult enough in the health service, but people do generally expect to see their GP and the same doctors going forward, and that continuity is helpful for people with any kind of disability, but particularly learning disability. And then the broader point about how we do that. How we make sure that people have access to the things that are really going to make a difference to their health outcomes. So those kind of assessments that you've done I wonder if there's a way that we can put some of that into the GP standard going forward, Nehal, in terms of, I'm speculating.
I'm happy to come back. So actually, the learning disability health checks is actually a national requirement now, which is great. There is a national specification as to what practices are asked to do. But I think that some really valid points. And I know Kerry mentioned the desensitization work that we did for vaccinations for this group earlier, that we really, our community services, our community team for people with learning disabilities really led on, and then we did everything we can to support both adults and children actually with learning disabilities. And that desensitization work really, we learned a lot from doing that. I think our community colleagues learned a lot from doing that. And we have had some individual patients I know GPs have raised with me to say, you know, I've got this patient, I really need to do some tests. I don't know how to get that because of some of the issues you just described. And then we've put them in touch with our community team for people with learning disabilities. It's not always possible to really get the solutions that you want, but I think there is so much more we can all do to help each other to manage this cohort and support this cohort to get the tests that we need. I don't think it will be something we can put in the standard.
No, that was ambitious of me, I know. yeah. No, but if it's a national requirement, we can look at how our learning at a local level can inform what we do going forward. I think that's the kind of undertaking I was looking for. Right, let's move on. I've got Mr. Cook, and then I've got Councillor Matata and Councillor Steve.
Thank you, Chair. We've talked about the NHS, but there's one part of the NHS which seems to have been missed, and that's the contact, if any, with 111 and the ambulance service. Now, the reason I bring up 111 in particular is the North West London, during the summer, there was a discussion about the new contractor being used, and they were discussing actually getting training. Now, that doesn't appear to be in this report, and I wonder how much contact people living in the community have with maybe 111, where you're not going to get the same doctor talking to you all the time.
So the training element, not specific to Ealing, but the training element came up at the JOS.
Well, they supply the contract for Ealing,
yes,
and therefore Ealing residents will be dealt with. And
so,
it's that there seems to be a disconnect between what the training that they've had, the fact that they turned around and said they needed training.
Well, that indicates that there might have been a problem.
Yeah.
And I think the way to handle that is for us to have a look at what the training currently is, and to go away and look at what impact, what contact people have had with 111 from Ealing, because I'm cognizant that even for able-bodied patients, that's quite a difficult service to navigate still at times in this part of West London. So yeah, I want to be absolutely clear about what we're asking, and sometimes it may not be the people with learning difficulties who are calling 111 themselves, and that adds another layer of complexity to the situation. They may need help to access that service, but I think the key point is how accessible is that service, and how do we make it better accessible to people who need it most, because they're not obviously all going to be able to turn up at A&E en masse. No one can at the moment. So yeah, I think there's some learning and some work we can do around that, Kerry.
So if Alichan's in agreement, we can certainly go back to the power group and ask them if they've used 111 and if they've found it easy to use.
Yeah.
We could take that away.
We could take that on board, and if you dialed 111, that'll be an emergency if you call an ambulance or any other emergencies.
Yes. It'd be interesting to know how people access their NHS services, just what more widely, Kerry, as well. You know, what is the easiest way to go through your GP? Does that work for people with learning disabilities? Or, you know, how do they access NHS services? It'd just be interesting to see what the routine is in comparison to, yeah.
So we were discussing this today. It's almost like we've guessed all the questions today.
Very good, yeah.
But the West London Trust provide the learning disability community team in
Right.
Ealing. They share lots of information with
Hanwell.
people who use the services,
Yeah.
don't they, Alichan?
Yeah, they do.
And it's certainly something we can go away and ask them, Mr. Clark, just to make sure, to get
Yeah.
people's experiences of the processes.
Does that sound like something that'd be useful?
Yeah.
Yeah.
It will be interesting for 111 and also for LAS, because LAS actually are the providers of the 111 service in North West London.
Indeed. Yeah.
And the reason I know is because I actually sit as
I know the reason
as
why
a
you
service
know.
rep.
Yeah.
On
But-
that, so I know
It's
what
really
that-
important to get that up-to-date information, isn't it? Yeah. Councillor Mataza.
Thank you, Chair. I would like to make few comments about what have said so far, and I would like to have a question. I echo most of the things which have been said. The point of access, and especially with this cohort group and the people with severe frailty, practices are supposed to have a bypass number, which should be given to the carers. And when their care plans, annual care plans are done, it should be written in their care plan, and the care plan should be printed and handed over to the carers. This has recently become a standardized practice because of the use of certain templates. So all the providers should use those templates. And at the end of the template, it is a very comprehensive template, recently introduced. At the end of the template, when it is completed, it has to be, it gives you an option to print out, and that has to be done and handed over. That's one point. The other point which Fabio said, that continuity of the care. So this is one of the area where CQC also keeps an eye on things when they visit or check the data about the practices and the providers, whether they are keeping it up to date records and all those, especially with the people who have special needs or learning disabilities or frailty, and whether the practices are taking special care of them. So some of the practices prefer to do their partners or senior partners to do these special tasks so that they know what is happening. By using that templates, the practices, and I can add my personal experience, that there are few themes which develop, which are coming out, especially what Carrie said, the transition in that area. For example, as my colleague, Dr. County has mentioned, that the blood test and the ECG, also their dental treatment. And another very important theme which has emerged in the last couple of years when I was doing the learning disability checks, in the transition period, we need to have some sort of support for the individuals when they are going through the puberty and the issues related to puberty, and some of the incidences where it has become slightly embarrassing for parents and for the individuals as well. So these are the issues which come across. So I was just wondering if we could have a specialized service to address this psychosocial and related to puberty issues with the learning disability. I have mentioned that the access, that it is important that the providers should have a bypass number for the learning disability. So that will cover much. Thank you.
Thank you, Councillor Mataza. So I think that's kind of what Harry was talking about in terms of transition and those transitional arrangements, because that covers a whole range of things, but it is the journey from being a younger person, clinically a child, towards adulthood and beyond, actually, you know, into that different phase, because oftentimes you're dealing with different practitioners, you're asking different questions, you're trying to anticipate what is going to come up. So I think if we're working on these themes, I wonder if we do a similar thing to how we did it previously, to ask the power group specifically through your meetings and through your work, what is their experience of the transition arrangements at the moment? You know, how do you find that? Where can it be improved? And you know, what do you want from it? How can it be better? And how does it meet your needs? And then, if what Kerry is suggesting is that you come back with sort of periodic updates on what you're planning to do and how you're planning to implement, we can monitor the success or otherwise. And obviously Neha and her team and her colleagues are going to be involved in that process as well. Does that sound, Councillor Mataza, like, because at least then we would have oversight of that, and yourself and Councillor Conti, with your experience in the field, be able to add your viewpoints and indeed your expertise from the cases that you see throughout. So we'll proceed on that basis. Councillor Steed and then Mr. Chesters.
Thank you, Chair. Thank you, Kerry and Alakan, for the presentation. It's a big report and it's an ambitious report. I'm just asking about the funding, and to what extent is funding for this, you know, ring fenced or guaranteed over what kind of period of time? Because it's full of good intentions, but how are you going to get there?
It's a very good question, Councillor Steed. In terms of the money, there's no additional money allocated to this work as yet. This is the initial position with the commissioning strategy. As we develop the plans will be funded or costed, and then we'd look to finding funding streams to support this. So there's no guaranteed funds in effect, but what we'd look to do is, by supporting people be safer in the community, and by supporting them use public transport, it enables people to be more independent.
It's all very laudable, but I can see a recommendation coming out of that particular element of this. I'm going to go to John now.
Thank you, Chair. It's more of an offer in many ways. I've heard transport mentioned a few times, and I just want to make clear to everybody that we actually provide transport, some of it free to users, to get people into GPs. And if it helps us to come into the power group to discuss that, could we still have a lot of capacity on that transport? And if we can find ways we can make that better, then we'd be keen to do that.
I think there's almost another offer there. When we were talking a little bit earlier on about the advice we give to people with learning disabilities about travelling on public transport, you've got some schemes whereby you can facilitate residents to get around the borough. And I think that's really, you know, there's a potential there as well, not just in terms of accessing GP services, which is obviously very important, but those social journeys or some of those other trips, and making it safer for people, you know, for the power group, for instance, to get around the borough. You know, I could see a role for ECT in that, and almost adding it to those care plans and promoting the services. You know, this is what we should be doing. I'm surprised we aren't, you know, that's something that we can immediately look at as to how to integrate ECT into this with your agreement, John, of course.
No, definitely. And travel training has been mentioned as well, and we've actually just been discussing with Cheshire about what ways we might be able to do travel training. So there's a conversation around that as well. More than happy to do so.
I think this is one where we put you in touch, and we almost add that into what you're going to report back to us on. You know, see what capacity is available, and you know, we might be able to customize some funding bids and things out of the things you're about to bid for as well. Go on, yeah, please.
I also do the TfL Valuing Network with John Hersoff. He does TfL Valuing People Network meetings. It's held once a year with him, and he organises it at the TfL building at the Palastra, or online on Zoom or other ones as well.
How do you find that experience? Is it a good experience for you?
It is, yeah.
You feel like they're listening to what you have to say, and they can make the changes you want?
Yeah.
Good,
Yeah.
good. Well, and again, I'd like to get ECT into that TfL space as well, potentially. Let's be ambitious about it. Yeah, Alan, go on.
Several years ago, TfL used to do an introductory system of taking people onto their transport systems and how to use it. Does that still exist?
It still does to its day, yeah. You've got the Elizabeth line and all other trains and other services around TfL.
Maybe just about getting that word out, maybe even wider than the power group as well, to sort of, because that's part of your transitional arrangements, isn't it? At a younger age, you're accompanied onto the travel network and you have support in getting around. And then sometimes you don't want that support, you want to do it yourself. And we need to make sure that everyone's comfortable and confident in doing that. No, I think that's a really good suggestion. So perhaps we can inquire as to CFL as to what funding and what support is available for our young people, so that they can go about making these journeys. But yeah, absolutely. Let's have a look at what where ECT can add value. Right, we've got Nehal. Sorry, Nehal, you're waving at me. Go on.
No, it was exactly around that ECT offer. As you know, we have the Plus Bus for Health, and that, our practices and our local residents have found that really valuable. So we can make sure that that is reiterated, that this group of population should also be able to access that service.
If there's a way of displaying it sort of more prominently in some of our some of the NHS communications, or some of the stuff that GPs might put out to their patients, essentially, to make sure that that's another way of accessing services. Right. I'm going to do one swing round of our colleagues online because I haven't come to them yet. Then I'm going to go to Mr. Willis because Mr. Willis has got a question. So I'm going to pause to see if anyone wants to indicate online if they've got a question. And I know I'm conscious of I can only see some of them, but I'm being told no. So Mr. Willis, are you ready to come off mute and ask your question now, please?
Hello. Sorry, I had some trouble with my sound earlier. Hopefully you can hear me now.
Yeah, loud and clear. Go ahead, mate.
Good. Yeah, I just wanted to preface my question by saying, obviously, we welcome this report, very comprehensive, the way it was done, and very well laid out. But there have been many reports on learning disabilities over the years, and our concerns are to do really with the implementation and how to achieve the goals that have been laid out. So just to say that obviously the report details a 5-year timescale and the 7 priority areas, but there's few details of how this can be achieved, or where the extra funding, extra staff, or extra training will come from. And also many more agencies than social services and health need to sign up to this to these ambitious goals. Obviously, we've heard a bit about TfL, about ECT transport, but I'm worried about will local employers sign up as well. So really, I think the question is, how and when will people with learning disabilities or autism and their carers be able to hold the council to account for this plan? Will there be regular progress reports to representative bodies on the progress of this whole report? Thank you.
Thanks, Roy. So I'll just cover off a couple of those before I come back to Kerry. So we're going to take some reports. I think that's quite clear, and that's committed to by Kerry, and we will make some recommendations before we finish here about what that will look like, and also what we want, frankly, in terms of commitment. I do know that in terms of our apprenticeship schemes and some of our wider employability offers as a local authority, we do encourage businesses to make pledges in respect of employing people with learning disabilities and physical disabilities indeed as well. But I do, that probably does need to be fleshed out a little bit more in terms of the ambition of the administration and what we can aim for. And I think that'll be helped by one of the recommendations we'll have to make around, because there clearly is going to need to be some finance pledged to this at some point. And we may need to make a recommendation around that. But I would expect, Carrie, that this would feed into a cabinet report, possibly into the health of the borough reporting framework, and maybe into Health and Wellbeing Board as well.
Thank you, Chair, and thank you, Roy, for the questions. So this is the first stage. We've brought the strategic document to the Health and Social Services Scrutiny Panel for scrutiny. The development of the action plan will be through the work that Alichan and I do within the Learning Disability Partnership Board. So there's full engagement with people who use services in the wider community in terms of what the action plans are. And as per Councillor Steed's question earlier, when the implementation plans are developed, they will need to be costed and considered within the wider funding requirements to implement them.
So I think that's going to be crucial. And I wonder if we should move on to how we look to implement this and monitor the implementation now ourselves. So Councillor Conti made some points earlier on about those health-related items of particular importance, and I think we've noted those and had the assurances from everybody that we're going to look to do that. The crux of this, though, boils down to the questions that Councillor Steed and indeed Roy just asked. So the first one is around money, and I know it's difficult for the council to commit to money, but this is an ambitious plan. It's going to be need to be supported by, frankly, cold hard cash. Because there are only going to be more people with learning. If the thing we've learned from the pandemic is that there are more people with mental health conditions, there are more people with learning difficulties than we previously imagined, and it's important not to limit their potential, right? So, I think it is pertinent for the council to explore immediately what financial resources are available to support the widest possible implementation of this. But I also envisage that other departments of the council will be able to assist in terms of education, for one, in some of this. I would expect some transport funding to flow through the transport related items. I think there is a case for Kerry as the strategic director to make a bold pitch to his colleagues and to the senior leadership of the council to say that this is a key agenda. We want to demonstrate very clearly at the outset that we want to fund as an ambitious a programme as possible. And as long as it's aligned to strong objectives, clinical need, and we can demonstrate that the money is going to go and be effective, then I think we need to be quite clear about needing to have a clear intention from the council quite quickly about how we're going to fund some of this work, even if it is making sure that the power group has the resources to do some of the work that we can do. In terms of I welcome Mr. Norman's offer earlier in respect of supporting with some of the surveying and the work with the GPs. I think there's really goodwill out there to make this happen, and there are a vast number of funding pots that we can dip into. But the council's a key player in that, isn't it, Kerry? We need to make sure that we're on the front foot here. I don't know, you probably want to come, but yeah.
Absolutely, Chair. But I need to be really clear on is that the development of the work plans will come following the strategic document. And that's the point at which we have the discussion with regarding funding resources.
Yeah, I understand that, but my concern is simply that the costings of these things, we should not be limiting the breadth of what we can do based on you know what I'm driving at here. And I just want to be absolutely clear that we want to make sure that the Power Group and its and the learning disability community as a whole, MenCap, all the other organisations. Yeah, please.
And the other organisations such as Speak Out in Hounslow, they're based in Brentford as well, and other organisations as well.
Yeah. So the Mayor of London has some funding in this area too. I think we should be, and I know Kerry wants to, and you're absolutely right. We have to define what we want to do first. But this is a bold agenda, and it needs to be supported with resourcing. So I think one of our first tasks is to have some more clarity around how that's going to be achieved, even if it's an indication of what pots the money is going to come forward from, and within the current financial picture that money is available and can be allocated, can be with the bold goals that we're setting out here can be met, because otherwise it's pointless. Yeah. Okay. And then I think we can go through some of those questions that were asked and some of those themes that were pointed out. So there's clearly an ambition from the panel to look at transport as a distinct area and to utilise the ideas of all of our co-optees here this evening in their respective areas to try and give as much support as possible. And I do think there is much more ability to work with a wide coalition of voluntary sector groups, more than are just represented here this evening, in terms of getting the widest possible access to services. Because I think there's a lot more expertise that we can tap into, and probably lots of people are doing some of this work, and we can capitalise on it. But and I just want to make sure that nobody's got any other points they want to make before I finish with just one more comment. Oh yes, sorry, it was Mr. Willis's point about other departments, other services, other agencies coming forward. This needs to be a council-wide approach. It can be led by adult social services, but there's no point us making this great step in parity of access and care and support for people with learning disabilities if it's not matched by every other department of the council, in my view. I mean, that comes through in all of our casework, that certain people struggle, particularly with digitalisation of services, Kerry, to access the things they need from a local authority. So I think there's learning within this document and within these areas for the council as a whole. And I would like to recommend that you have discussions with your other directors and other members of corporate board about what their departments can do to make their services more accessible to people with learning disabilities, and use the Power Group as your sort of testing ground for hypothetically how does the Power Group how do Power Group members access services in all these different ways, or how can we better? One of the things you said, and Anachan mentioned it earlier, about writing to TfL and writing to various groups and receiving letters. We don't always put our communications in the most accessible form, and I know that sometimes that's true of the NHS as well. Sorry, Councillor Steele is waving me down. Go on.
No, I just to try and sort of bring this to a close, maybe. Forgive me, Kerry, I can't remember. Have you got a time plan for the next stages of the process, or?
So we've got the working groups are up and running.
Yeah.
So as part of the Learning Disability Partnership Board, so as a clear framework, some of this work will take longer than others. So we know from the accommodation perspective that that's fairly well progressed. We're having discussions, as Councillor Crawford has said, with colleagues in the place departments of the council to progress those. But what I'd propose is that we bring an updated piece, maybe 6 months' time.
You know, how many meetings of the partnership board would you envisage before we're getting to a point where we know what we're asking for, if you like?
I think it's difficult to define, Chair. I think in some areas it'll be quicker than in others.
Sure,
Some
sure.
will be more
But
complex.
you want to make quick progress on this.
Yeah,
you know?
absolutely. Otherwise, we'll have all moved on and be doing different things, and people
Yeah.
won't have benefited from this good work.
So if I'm saying, if we're saying by the summer meeting of this panel, and I don't know that we have confirmed dates for this year. We do. We just don't know who's going to be overseeing it. But yeah, by the summer meeting of this panel, then we can receive a report about what that will tell us what areas are advanced. Yeah. So what, 6 months from now, July, August, time, September.
Yeah. So we can bring you an updated position on progress against each of the areas of priority.
Yeah. And I would ask that we look at that there is some estimation of what the cost implications of those will be.
Yeah.
Because without that, we don't know what we're green lighting. And if we can include in that some communications with colleagues who've expressed interest in helping this evening, then that will help us to provide a wider range of services. Right. And I want to finish with Alichan. Is there anything else you want to say?
Yeah, I go to, I sometimes help out with Karen Jenkins at Blondin Park with the youth engagement program. Not all the time, but sometimes when I need to.
Excellent. Excellent. And what would be really interesting is if we could learn more in that report about the power groups ambitions for future work and how we're supporting, you know, what you want to do 6 months from now. What are your priorities? If we could have that voice of our learning disability team in you know, really at the heart of what we're asking for.
The priorities are as set out in the strategy, but we can keep, Alichan, if you're agreeable, we can keep coming back.
Yeah, we could do that. Yeah.
Yeah, I'm just conscious that when I hear from what Alichan is telling us about the sort of extracurricular stuff that is being done, that captures the interests of power group members. And that's important in showing us what else we could be doing and supporting as a local authority as well. All right. So look, thank you so much for coming and presenting this to us. Thank you to Nehar. Thanks to everyone for their questions. And I think the point you made a moment ago, Kerry, about this being sort of the first part of the process in scrutiny, you know, we welcome the fact of being able to influence this at an early stage. So thank you very much. We're coming straight back to you though for the adult social care quality assurance framework. But we might, Alichan, do you want to? You're going to stay. Excellent, excellent. Right. So, Kerry, you're going to present on item 7, our quality assurance framework.
They've been. I can talk to that. If you can share them, that's fine. But
well, let's see about the wonder of technology here.
Yeah. So, thank you, Chair. As this was discussed in one of our previous meetings, that we're going to bring back regular updates to the Health and Social Services Scrutiny Panel in terms of the performance reporting framework, in terms of quality that we use in adult social care. This is the data from December 2022. The first table shows the number of contacts to the front door of the council for adult social care. The lower line shows the number of those contacts that progress to an assessment. So approximately 10% of people who contact the council regarding social services issues progress to an assessment. In effect, that means 90% of people are having their needs met through advice and information at that point of contact, and only 10% progress. That's positive. You will notice that there's a steep increase in the number of contacts post December 2021. We think this is following lockdowns and also increases as a result of the cost of living crisis. The next slide gives the information on the waiting times for assessments. This is how long people wait from point of contact to assessment. This is good performance, probably consistent, no, not probably, this is consistent performance in terms of the average waiting times being around 30 to 35 days. I think this is a really important indicator in terms of customer satisfaction. Nobody likes to be left waiting for a service or assessment. Next slide refers to the number of people admitted into care homes over the age of 65. This is in line with the wider council's direction of travel to support more people in the community. Throughout 2020 and 2021, in response to the COVID pandemic, we saw significant increases in people being directly discharged from hospital into a care home through what was known as the discharge to assess model, where NHS were placing people direct into care homes and saw a significant increase in numbers. Over the last 12 months, we've been working really hard to try and rebalance that approach and support more people live in their own homes. What I tend to do is to look at the 3 months previous data. So I'm looking at the August data, which allows for any lag in data quality, where 107 people were admitted into care homes compared to 142 in the previous year. So you can see there's a significant shift in terms of the approach that's being taken. Number of referrals and breakdown of ethnicity. You'll see there's variations and reflective of the communities that we serve in Ealing. We're relatively happy in terms of the representation of people referring for assessment, but this is something that we keep under constant review to ensure that we've got culturally appropriate services. The next slides talk through the Care Quality Commission's rating of care providers in Ealing. We've got over 108 registered providers in Ealing. Over 50, more than 55 of these are home care providers. As I've mentioned before in this meeting, we've got the 5th highest number of care homes in London and the highest number of care homes in northwest London. So a significant proportion or a significant chunk of the market for northwest London sits in Ealing. Our influence on the registered care market is fairly limited. We procure approximately 30 to 35% of all the care home beds in Ealing because we're a net importer. So Hammersmith and Fulham will purchase a lot of beds in the Acton area. We also put levers on the market in terms of where we procure services from, and we'll only buy home care services from good and outstanding providers. The next table shows the improvements in terms of the CQC rating trends data through 22-23, and you're seeing improvements in the good and outstanding providers in the borough. There's been a lot of work between Nehar's colleagues and my colleagues in terms of providing additional training for registered staff in Ealing. We've seen over 100% increase in registered CQC service, people working in registered CQC services, uptake of training that's provided free at the point of contact by the council. We're also looking at developing further targeted resources to work with failing providers or providers that are having problems with their CQC rating. We've also been doing some work with Health Watch, who did some interim reviews with a number of providers in the borough, and I'm pleased to say that supported those providers improve their CQC rating, which I think is really positive. There's then the breakdown and the CQC ratings for the range of providers. The issue that we face in Ealing is that the rating quality concerns are within the nursing home sector. So this is something we're looking at with NHS partners. Currently, as I said, the domiciliary care sector is fairly buoyant, good standard and quality of care. Residential care is generally good in Ealing, and services for people with learning disabilities and mental health needs are generally rated more highly than for older adults. So that's talking about the activity flow data that we collect. We then move into what we do in terms of our quality assurance frameworks for our directly provided services and how I keep quality assurance of the services that are provided directly by the council. This includes a range of case file audits, which we complete on a regular basis, which feeds through to examples of good practice and areas of development, which then influences our training programme for social work and other staff within the system. We also have 3 registered care providers that are directly managed by the council and a number of non-registered services, including day services. Because of the hiatus in CQC assessments of the registered providers and to share their best practice within the provider service, we carry out mock inspections, for want of a better term, and audits of the provider services where the registered managers visit each other's services, carry out audits based on a template that we copy from CQC, and we also carry out services of people who receive. Sorry, I'll say that all again. We also carry out surveys of people who receive our services to get their satisfaction levels and use that to feed into the quality management of those services. All of the 3 providers that the council is responsible for in the borough are all rated good with CQC. We haven't been inspected since before the pandemic and we want to keep the rating as good, so we need to keep everybody on their toes. So, Chair, over to everybody for questions, but this was an action from last year for us to bring this on a fairly regular basis to be accountable to the Scrutiny Committee.
We appreciate you delivering on what we agreed was an important part of our oversight work. Right. Colleagues with questions on elements of data that is within these reports. I'll start with Councillor Compton and I'll come to Mr. Cook.
Thank you. It was just really on the care home admissions, and obviously done a really good job of keeping people out of care homes and in their own homes. I was just wondering, in terms of the workforce, for ensuring that those services are sustainable in terms of that ongoing trend of ensuring that more people are cared for at home. What does that look like? Is there good retention within that workforce to ensure that there's sort of security going forward, that's something that's sustainable and to be able to continue and build on?
Thank you, Councillor Contis. It's an absolutely key point that you're raising there. As you move people from institutional care into community services, you probably need more staff because it takes time to travel around and to support people in their own homes. Workforce is absolutely key. In terms of the home care market, domiciliary care market in Ealing, it is very dynamic. We've got a lot of registered providers. We're very clear in terms of our quality expectations that they have to be good or outstanding for us to procure new services from them. We work closely with them in terms of the training that we offer, and we work with Skills for Care to support the quality of the sector. And we've worked really hard. Some of my team have worked extraordinarily hard to implement the real living wage within this sector in the last 3 or 4 months. It came live in November. So we think implementing the real living wage will add to the stability of a dynamic market, which is really positive.
Okay, Mr. Cook.
Thank you, Chair. I've got some concerns about CQC reports, which I actually given you earlier. I'm still not actually all that happy with the situation. I think my big concern with CQC is the fact that when we first started the inspections, a lot of the homes were actually graded as good. And what concerns me is over a period of time, how that has deteriorated. In fact, currently we've got a number of homes that are now worse than what they were when things first started. And in particular, an issue that goes back to the previous thing we were talking about, people with learning disabilities. There is one home that is used in that sector, which every single report has actually required improvements. And basically those improvement situations is the service safe? It needs improving. And is it well led? And again, so what concerns me is there doesn't appear to be, I know in the previous report that you presented, you said that you're now only doing outstanding and good. But the problem we have is we've got a number of homes that are not actually meeting that. And in particular, as I said, this last case where every single report requires improvement. Now, if it was a big home, I might not have such a problem with it, but it's the smallest. Sorry, I'm not going to mention names to make, but I do have difficulties with that. And I wonder what the council are going to do. Yes, okay, we only purchase 35% of what goes on, but I think that's a third of what goes on. And I think we should be.
Okay, to respond, thank you for the question. So we only buy home care services from good and outstanding providers. In terms of the care home market, it's more complex in terms of how we would achieve that, but it's something we're constantly looking at and challenging ourselves around. We had a care home summit last week, the week before, with provider partners, with NHS partners, with the whole system, to really look at the issues that you're raising in terms of how do we really make a difference. I think your point, Alan, with regard to well-led is absolutely key. The average length of stay of a registered manager in a care home is 18 months, which is inordinately short. You cannot change and maintain a culture shift in that short period of time. So these are specific areas that we're looking at, and we're developing some strategies through our commissioning arrangements and with our partners, the NHS, and hopefully with partners across North West London, so they can really target some of the providers that are having these difficulties. I regularly chair a risk review panel where there's concerns about providers whose rating has dropped, and we sometimes have to make some very difficult decisions to stop contracting with providers who can't maintain good performance. But it is a challenging sector.
And I would say, just on the CQC point, you know, we've had some correspondence with the CQC. We're going to try and fit them in. I think at some point it's been challenging. We ourselves, as you know, lost a meeting to try and fit together our agenda, and we've got certain things that we have to do by April in order to fulfil our work program. But you know, whether it's me or whether it's somebody else, we'll certainly put on the work program that we need to have a look at and hear from the CQC. They have written us a letter and communicated with us. I'm pretty sure that's been shared, but I can make sure that it is again, Alan, so that you've got sight of what's been said. And I would just say as well, there's a limit to what local authorities now can do in this space. You know, a lot of these services are at the beck and call of the market and at the beck and call of the regulator. I don't think the regulatory framework is sufficient, frankly. Certainly not in terms of, and there'll be reasons for why that is currently, that we're so far behind. But you know, these are all concerns that I've shared with Kerry in respect of how we. And I'm sure it all comes through in our own caseloads as councillors when we hear from people who are getting substandard care. So maybe it's one for us to take away and look at and provide some more information to panel members and see how we can carry that forward, Kerry. Go on, yeah.
And just to add, the proportion of CQC rated providers is now at good or outstanding is now a corporate target. Is something that I'm held to account to organisationally and by members, so it's clearly part of the programme. Yeah, that's all registered care providers. Yeah. So, but as you said, Alan, that we know we've got specific concerns and issues with some nursing homes.
Part of the thing that I would say, this comes under CQC. So this comes under CQC. Why aren't CQC themselves insisting that the standards are brought up? That's again.
Well, I think they have capacity. I'm not here to defend the CQC, but
No.
I think they have capacity issues in terms of getting around and carrying out all the inspections that they have to in any case. And you almost have to give people the ability to prove their compliance with or meeting the targets that are then set out. But you know, it's effectively a vicious circle, isn't it? The sector is understaffed. The retention rates of staff are low. As Kerry is saying, you know, you've got a centre managers are there for a year and a half, the average stay. And, you know, if you're trying to turn around an organisation, you've got to recruit new staff. You've got to hold them to a higher standard. You're only halfway through that process after 18 months. But look, I know, I sense you feel strongly about this. Let Kerry and I have a chat, and Councillor Steve and I have a chat about how we can present you with some more information and look at how, because Kerry's absolutely right. He's held to account on a council-wide range of targets now in respect of how we commission, what we commission, and the quality of those services. And that's a corporate board level target. I think, an administration level target. So we can certainly give you some more information about how that is being progressed. But there are, you hint at wider problems within the sector. So let us take it away and undertake to provide some more information, and then we can see how best to disseminate that. Right, Councillor Mohammed's been waiting a long time. I'm sorry for doing. Are you ready?
Yes, thank you, Chair. I have got a couple of questions on the presentation. Thank you. That was a very detailed presentation. The first one is the slide 3. You mentioned about the waiting time on average is 35 days. Is that based on a national guidance on the number of days to wait for an assessment? And I also noticed on the numbers, there were some that exceeded the 35 days in that slide. And wondered why, if it exceeds the average number of days, what's the reason behind it and how you manage that? My second question is regarding the audit that you do, the last final slides where you said that the managers audit each other's areas. What assurance do you have these managers possess the necessary skill set to carry out a sort of a CQC methodology, as mentioned that the last couple of CQC that has been assessed the care homes has been improvement notice. So just wondered, what do they have in order to actually do a good audit, because they can be sometimes sensitized to the normal day-to-day problems and may not actually record it as a inefficient service or a problem. Thank you.
Thank you, Councillor. Again, some very helpful and useful questions. In terms of the waiting time for assessment indicator, the historic target that had been set by the precursor of CQC, I think they were called CSI, was 28 days. It's no longer a national target for waiting times for assessment. We don't report on this for any of the national returns. This is a local information indicator. So my preference is that the shorter the wait, the better, because again, that's a quality, that's a life experience indicator for us. The variations in the waiting times for assessment go back to Councillor Crawford's earlier point with regard to limited staffing resources and competing demand. We also do work around our reviews. We've been supporting and doing a lot of work with the NHS over the last 3 years, but more importantly, over the last 6 months in terms of winter discharges in response to winter pressures. And what my colleague Jackie Yates, who's the operational director, would say is that in effect, if you move resource to deal with reviews and get the reviews down, then the waiting time at the front of house increases. It's a basic physics issue that if we don't have enough resource and we're moving it around, we can't hit all the indicators. But it's something that I personally am very committed to, because this is where risk sits. This is where dissatisfaction sits. People waiting for assessment are people who we don't know anything about and are risk to themselves, to the organisation, and the sooner we can get to speak to people, the better. In terms of the second question with regards to the internal audits that we do within the provided services, what we tend to do is to use the registered managers, so that's the CQC registered managers. We'll do audits on the unregistered services, and then skill up and use their knowledge, because they're used to being inspected and the challenge of a CQC inspection framework, to share that understanding and knowledge with the non-registered services. It's absolutely right. People can get almost insensitive to what they're seeing if they're working within a service without external challenge. So it's really important that we use external managers to come in to look at the services to ensure that there isn't an insensitivity to where there may be issues and risks within the service. I get these reports on a regular basis and do hold colleagues to account on them.
Kerry, I think we're going to have to ask everyone to pause for a little bit while Windows signs everyone out and re-signs everyone back in again.
Oh.
It's one of those unfortunate system upgrade things that can't be helped, I don't think. Technology is brilliant when it works, isn't it? So what I'm going to do, Kerry, I'm going to ask you. Right, so sorry for that interruption, everyone who's online. Hopefully you can hear me and see us shortly now as well. I'm just waiting for, yeah, we're up. Lovely. Right, Kerry, I'm going to ask you to start from about 30 seconds ago. Or, you know, revise a bit of your previous answer so we can bring Councillor Mohammed back up, because you were just answering her second point. And then I think there was one more as well.
Thank you, Chair. So, Councillor Mann, the second part of the response was with regards to the internal audits that we carry out on our provided services. What we do is that we use the registered managers, so the people who are CQC registered. will go out and check on and support the non-registered providers, how to use the assurance framework that's been developed based on the CQC program. And then there's quid pro quo arrangements that there's visits across the management group. The managers will constantly change so that they're assessing and auditing another provider to ensure that we keep a degree as much as we can of probity of the process. I think you're absolutely right. I think that there is a risk that people become desensitized to issues within their own services. And this is part of our program to try and support maintaining the quality within.
Sorry, Kerry, we need to turn the video on. I think it's that video is not on for everyone who's online. I mean, I'm not sure it makes a massive difference, but yeah, now it should be on. Sorry, Kerry. Now they can see you as well as hear you.
Again.
No.
Just
No, not at all.
Thank you.
Can I just confirm, people online can now see the chamber?
Yes.
Lovely. Thank you, everybody. Right, carry on. Sorry about this, everyone.
So, so we carry out the internal audits, we carry out the surveys of people who use services and their families, and it's part of our assurance process. So hopefully, Councillor, that answers your questions. It's very difficult to have a perfect assurance model, but this is our attempt to get as close as possible to that as we can.
Thank you.
Thank you, Councillor Mohammed. Neha has been waiting an inordinately long time since she put her hand up. Neha.
That's okay, thank you. I suppose just a few comments and observations, because I think this is where our integrated ways of working can really have an impact. I mean, there are, Kerry mentioned all of the work happening around discharge out of hospital and into the community, and the role that social care play in that really key function, because if it doesn't, then there is an impact that you see in the hospitals, as everybody has been observing. And so just thank you to all of the social workers who've just been so patient and incredibly responsive right the way through winter. There is always more that we can do better, especially if we have the workforce crisis, because that really does have an impact on the front end as well. And, you know, for example, making sure we're not duplicating work and we are using the expertise of each organisation effectively and working really closely together, and making sure the NHS teams and the discharge teams are working really closely with social workers, and that we health understands the pressures in social care and vice versa, so that we can collectively come up with the solutions. And that's exactly how our integrated way in our borough partnership is evolving to try and address some of these really difficult and complex situations.
Thank you, Neha. I wanted to, have I missed somebody? I've got a feeling somebody else had a question. Maybe it was someone online. Maybe I'm just imagining it. Yes, oh, that's right. Mr. Willis, I kept you waiting. Roy, are you ready to ask your questions?
Yes, indeed. Yes, thank you. I've got two questions, actually. The first one's largely been covered by Mr. Cook, asking about whether there is an improving position on care providers. Obviously, we've got a lot of information to say that it is improving within domiciliary care, but that residential care is still at least 5 homes that have got requiring improvement on a succession of visits and contacts by CQC. So I think I don't need to go over all that again. But obviously it might be useful if Kerry could tell us what the council can do. I know he's mentioned a care home summit and a risk review panel. So is that and obviously the task of trying to improve training and improve leadership. Is there some way of perhaps trying to find out exactly why there's, you know, obviously the situation would be different in each of the 5 homes that are requiring improvement, but perhaps it could be some sort of report could be or more information could be provided on what exactly it is that's holding these homes back.
I think, Roy, what we'll do, we'll see if we can get something in writing on that rather than revisit that now. How about you ask the second element of your question, and we'll get Kerry to answer.
Yeah. Okay. Yeah. Yeah. As I said, I submitted that question a while ago, so obviously time has moved on. The other question is a broader question. Just about the costs of equipment that people have at home, and really to do with the cost of living. Some people with disabilities have complex equipment which is essential for their care, as well as household cooking and heating. This equipment adds enormously to the electricity bills and higher utility bills. We're calling for Ealing to arrange welfare checks by telephone to ensure that service users who need this sort of equipment are offered advice and financial assistance if necessary, and that this needs to happen, if it's going to happen, in the next 2 or 3 months, as energy bills have been rising. And when I mentioned financial support, I wondered if that could come from either the emergency fund, the household fund, or the welfare fund. I'm not quite sure what the difference is between these funds.
Yeah, sorry.
Thank you, Chair. Thank you for the
Can
question.
you hear me all right?
Yeah.
We got you, Roy. I'm going to get Kerry to answer you now.
Thank you, Roy, for the question. So the council has been providing a range of support to people living in and experiencing difficulties as a result of the cost of living crisis in the borough. Some of this is very targeted support to people with disabilities. And as I've mentioned before in this meeting, that if people are having specific challenges meeting the costs due to their disabilities, the council offers a disability-related expenditure reduction on cost for services, which we can review and expand upon if people's costs have gone up significantly, and would certainly encourage individuals to contact our financial assessment team to support that. In terms of the wider cost of living challenges that everybody's experiencing, Roy, the council's developed a team to look at this, and my colleague Louisa is leading on this. So I'll certainly share your thoughts on welfare checks with people with equipment to see if they have experiencing specific challenges with her and her team to see if that can be taken forward. However, I would note that there's significant challenges with staffing currently, and having the right people to carry out those calls could be challenging, but it's certainly something we can discuss further.
Okay, thank you, Roy. I would say as well that the council's cabinet has introduced more cost of living support since the last time we met as a health and adult social services scrutiny panel. We've expanded our hardship fund significantly. That's to all residents, but I think it would cover a number of these constituents to which Roy's group are rightly concerned about. And all those packages of care would remain under review, as I believe I'm right in saying, in terms of any increases in costs. But I think it is probably worth us having a look at potentially looking at where we might be able to assist people experiencing significant difficulty. So we may have a look, depending on what comes back in our next work program, because I'm not going to be able to fit it into this one, about the specific help that is available, how targeted that support is, and particularly I think for people with learning difficulties and physical disabilities, what is out there, because it's been a long time since we had a review of the range of services and support that is available, and hopefully that goes some way to indicating that we're open to addressing Roy's concerns through this through this forum. There's also the Health and Wellbeing Boards and the Council's Cabinet that can take up specific questions. Councillor Mohammed's got a hand up. It's not a legacy hand, is it, for doing
No, no, it's not. Thank
yeah.
you, Chair. This is just a suggestion, just echoing what you said about that, you know, the funding of hardship. But it will be useful maybe at the next meeting to see what information or assistance in terms of monetary has been provided and who actually benefited and actually received that. I recall that you mentioning about systems and digital, not everybody has access in actually getting the hardship funding. So it would be useful to see if there's any data to indicate if that has been benefited for the vulnerable groups. Thank you.
So we can certainly pick some of that up in the health of the borough item. Probably there is I should draw attention, and my scrutiny officer has reminded me of the fact that we do have a tackling the cost of living scrutiny panel that's currently in operation. So what I will do to take away an action point is have a look at what they have done so far, and I'm sure they do have one more. I was about to, yes, indeed. I thought Councillor Alexander's hand was going to go up, and there it is. Councillor Alexander, please.
Thank you, Chair. Yes, we have done a lot in regards to payments, in regards to hardship payments and discretionary housing payments. If Councillor Mohammed would like to look at on YouTube, they're recorded and she can have a look back at things, and I can also give her some information if she would like some information as well.
I'm sure we can circulate some of the relevant reports from your previous panel hearings as well, Councillor Alexander. Yeah. Okay, she's on mute, but I'm sure she wouldn't have a problem with us.
Yes.
Brilliant.
Sorry.
Thank you. Yeah. No problem. I just want to make sure I got your consent to do that, because there is quite a lot of help that we put out there, but we're certainly open to assessing and analysing how effective that's been, so we can learn some lessons. Right, I'm going to try and draw this one to a close. I'm just checking. Councillor Alexander, did you want to come back in, or is that an old hand? I think it might be a legacy hand. It's okay. Right, I'm gonna press on in any case then. So this was an update report, and I think it's important to see some of those, some of the positive elements, but panel members have addressed some of the areas where we have some enduring concerns, and I don't think they're a surprise to Mr. Stevens and his team. And I think it was incumbent upon us then to go away and have a look at how we can keep the panel updated on progress in this area. And I think the recommendation therefore is that Councillor Steed and I and Mr. Stevens convene following this meeting, and perhaps at our next pre-meeting, to discuss how we can keep this item in our work programme going forward. I know there are further updates scheduled, but there's a couple of specific points with regards to the CQC, with regards to review waiting times, and with regards to general sort of national guidance and targets that aren't there anymore, that we might just need to flesh out. And you expressed a personal preference for what you would like to see locally, but it may be time for us to sort of look at what are the local targets. You know, can the administration set some targets? Are there any frameworks? Is there best practice that we can employ? But let's have a look at how we scope something as an update report to come back before a future panel. Right, I've got one more item for us to get through, and it's very important because Daniel Norman is here from Health Watch. We're going to look at some of our patient experience reports. Daniel's going to take us through the report that is in front of us. We've got some recommendations at the back of that report, and then we're going to have questions and comments. Daniel.
Thank you, Chair.
I'm aware that there's a question from the public, and I figured I'll use that question to create some context for how we collect the data from the report.
Fantastic. Go ahead.
So this is a quarterly report. This covers Q2, so that's July, August, and September of last year. The first part of the question asks about quality of care and how we assess that. Second part of the question asks about how we follow up with patients providing negative feedback. And the last question is around some GPs that receive less reviews than others. Attacking question part A, in terms of quality of care, we ask about treatment and care to patients in the waiting rooms of GPs and hospitals. And from there, they provide sub-themes around their experience, the support they were provided, and what they felt was the level of quality they received in that care. It is theoretically possible, because we are getting opinions, that a doctor provided outstanding best practice care, but a patient felt that he wasn't heard, listened to, or respected. So this is a snapshot of their positions, their feedback, their opinion, and that's how we assess quality. Quality is built around the interaction of the patient and the medical professional, whereas experience is the totality of everything, including, front of house admin. In regards to chasing up patients that provide negative feedback, with consent, we are allowed to keep that information and jot down their information and, consider what they've provided with us. Normally, negative feedback is around kind of waiting times, access to that care. But if there is a serious incident, we will often signpost or support them in reaching out to advocacy through Voiceability, who provides local advocacy in Ealing. But if they want to take that further, we can assist them in any way they want to do it, as well as communicating that to the GP themselves if there's a serious issue. With regards to not enough reviews on some of the GPs, Ealing is large, and there are quite a lot of GPs, and my team, although they do an absolutely fantastic job, we have limited resources. So sometimes over the period of 3 months, we're only able to visit a GP once, which is why there is a small amount of reviews, as they're all done in person. So with that, what we've done is, if there are less than 10 reviews on the report, we don't show each review individually, because we think that would give a negative impression or an overly positive impression without the actual details. So if there's less than 10, we don't kind of present all of it very clearly in the data. However, what we do is we do follow up with those GPs. So we make sure that we accurately get a grasp of the trends. So if a GP has received 4 reviews and 3 of them are negative, that's worth following up next quarter. And we will endeavor to get, hopefully, multiple reviews in the double digits. And if the chair is okay with it, I'll give a little shameless self-promotion. On HealthWatch Ealing's website, you can find all the quarterly reports, so you can identify the trends with your local GP. And you can see, hopefully by looking at the last year, you can get 20, 30 to 40 reviews and get an accurate perception of maybe how your GP is faring. I hope that answers the parts of the question in totality. I will do my best not to bombard the scrutiny panel with numbers, but just try to give some context to the GP and hospital results. The report is basically broken into 2 parts: the quality of care received and the access to that care. And unfortunately, kind of that's where we see the numbers diverge. GP overall positive quality of care was at 89% for this quarter. This was the strongest quarter for the year, but it is very much in line with the numbers that we see quarter to quarter. We also saw 80% in positive GP support. Now, this is interactions with the doctor, understanding what the doctor is saying and the care that they are providing. Where we see the numbers kind of flip is we see 76% negative around patient choice. Patient choice is normally how they would like to interact with their doctor, or how they would like to receive information, or get repeat prescriptions, kind of anything that's kind of involved in GP practice. The other negative number that I want to highlight is 58% negative getting through on the phone. This can't come as a surprise to anyone, but the difficulty we want to highlight, just because it's one of those stark contrasts where we see really amazing numbers for quality of care, despite the level of pressure that GPs are currently under. But we know that there exists frustrations, and that's about seeing their doctor interacting with that care. We see something similar at the hospital. Here, the number of positive support reaches 91%, which again, Q2 is fantastic. However, for the year, having the numbers now, I can say that hospital positive support has always been above 80% for the last 4 quarters, which is really just amazing. A negative number that I'd like to share, which actually isn't that bad in context, is 44% negative when discussing waiting times. That's on-site waiting times, so not waiting for the appointment, but when they're actually at the hospital. So that means overall waiting times were actually positive or neutral. Where the negative numbers and the positive numbers interact is when we look at the overall experience. So for example, when we look at GP over positive, I mentioned the 89%, but then we take into consideration that 76% negative patient choice, and we come to an overall 66% patient experience positive. So we look at over roughly 3/5 of the patient experience is overwhelmingly positive, where we see that issues around getting access to the GP or the nurse or their specialist tends to bring the rating down. If I can conclude with just some of the recommendations, throughout the year and throughout my time starting in April with HealthWatch Ealing, we're seeing a stark contrast and consternation around patient choice. Patients are frustrated. They don't feel like they always get to choose how they see their GP. Sometimes virtual is beneficial, but sometimes patients feel like in-person is not just convenient for them, but it's the best way to get their message across. And if they don't feel like they can communicate with their doctor in an effective way, that's going to bring down the overall quality rating. And we hope, but it's possible that it affects quality of care, at least in the patient's eyes. So we want to emphasize the importance of prioritizing patient choice. We want to emphasize the need to recognize that as things go more and more digital, there needs to be more online support. Otherwise, we reduce the access through that channel as well. And then the last one, and this came up in Q2, and if anything, it's gotten louder during Q3, is in discussion with older people's times of their appointments. For those 65 and plus who have free travel cards. The overall preference, and again, I wouldn't dare speak for all people over 65, but preference is to have the appointment after 9:30 so that they can use their free travel. I don't know, honestly, how the best way to implement this is, but I do believe that consideration needs to be paid to the fact that patients are saying this is incredibly inconvenient, this is incredibly difficult, and also there's a fundamental benefit to patients coming in later who have free travel. Thank you very much for your time, Chair.
Daniel, thank you. I think it's important. So there were some questions submitted from someone who wasn't familiar, I think, with how these surveys are conducted. And I'll say what I said to your predecessor. I mean, I'm old enough and long enough in the tooth to remember the inception of HealthWatch and being very skeptical about how HealthWatch would carry out a wide range of functions and how successful they would be. And the work that your mostly volunteers do is exceptional in terms of giving us and you're right, it is a snapshot and it can only be that, given the vast number of GP surgeries and hospital sites that you cover. But it's an invaluable service for Ealing residents. It's an invaluable service for people like us to try and give us an idea of how each location is faring and giving that patient voice, which is all about what HealthWatch is about. So I think it's very important that we once again pay thanks and pay tribute to the hard work of you, your colleagues, and your volunteers who are getting that information across to us. It's ever so valuable.
Thank you, Chair. I'll definitely pass it on to my team.
Thank you. Now I wonder, is Nehar's there? Nehar, I'm coming to you, and this is very unfair, and I apologise in advance in respect of the last point there about appointments for people who qualify for freedom passes on virtue of their age, and the timing of these. Is there something that we can look at, or getting some communications out to GP surgeries about how we might better schedule some of those appointments? I mean, is that at all possible?
I'm actually curious about the detail behind some of the people that have said that. Is that for appointments at GP surgery or hospitals? Because I can understand it for hospitals because people will have to travel by public transport. I can absolutely understand that. And we can ask the hospital if there's any way that they can take that into consideration. I'm not promising anything given everything else they're trying to deal with at the moment, but we can definitely ask them. For GPs, I would be surprised if it's coming out that strongly, because they're usually within the community, quite close by within the community. So I don't know, I'll be honest with you, how many people then actually use public transport to get to the GP, and they absolutely may well be doing so. But I'd really like to understand some of the background detail of that.
Ask Daniel to come in terms of where we are.
Yeah, so apologies for any confusion. It is very much strictly to the hospitals.
So I can understand that, given the patient journey they are to our sites, and that would be easier to implement, I imagine, than asking every GP to block book out service provision. But perhaps we could look at how we might go about, and if you want me to write something saying that we've received this report and that's what's come out, and we'd like to see what we can do, then I'll be willing to.
I'll be more than happy to take it as a first conversation with the operational director of the of Ealing Hospital and London North West in particular, start with them and see whether it is possible or not, how feasible it is.
Yeah, I think we're just asking at the moment for some consideration to be given to, and if we can, then that'd be brilliant. But yeah, it's important that we try and implement as much of this feedback as possible. Thank you, Nehal. Has anyone got any questions? Andrew, I knew you would. Go on.
Daniel, thanks for your presentation. On this particular issue that we're just talking about, just sort of digging a little bit deeper, how big an issue is it? I mean, what is the percentage of research that people are going to hospitals as opposed to GPs? And
so for Q2, I don't have Q3's numbers in front of me, apologies, but for Q2, we talked to 215 people waiting at the hospital regarding their hospital appointments. Of those 215, 62 mentioned patient times in terms of their appointments. We talked to 592 people at their GP, and when asked about hospital appointments, another 32 mentioned it. So just under 100 out of the 1,200 odd people, 1,200 reviews. So it's a small percentage, but it was definitely the largest single recommendation.
It's a significant sample size, though, isn't it? It's not a small. It's not a small. It's a small number of people, but of the people who've expressed a dissatisfaction, it's
on that specific point.
Yeah, and the fact that it was repeated again in Q3 at least means that I'm going to try to keep it on the table.
You're picking it up as a recurring, as something recurring, and I would just say it's probably something that comes through because of the specific nature of the large. You mentioned how large a borough Ealing is, and for people trying to get to Ealing Hospital, for instance, you're having to travel quite some significant distance. It may be 1 or 2 buses, or a train and a bus, or And if you are of an age where you need to use well, you can use your Freedom Pass, I guess it does make a difference. Councillor Conti, did you want to come in? No, but you did want to come in. Yeah, go for it. Yeah.
I guess one point, I guess it's more to the chair really about obviously I know it's a very, very small sample size, but it talks about in terms of mental health, and what struck was the 75% thought they had a bad service. And I know we spoke about acute mental health issues at the last meeting, but I know it's on the forward plan, but with no date, looking about mental health services in general and their performance. And I just wonder whether that's something we can maybe prioritise as an item for the panel to look at going forward. So I just think that's, though acute services are important, that's really only sort of the very most severe cases end up there. And I think what we, inpatient, beds, what we need to do, I think, is look at the community service that is being offered. So I think that just struck, even though it's a very small sample size that we're questioning about mental health. And I guess my only other point was, in terms of the individual sort of ratings, I was just trying to look back and find the previous report, but I couldn't find it. It'd be interesting to see, are the scores consistent? So is there an improvement? Because I was looking at my own GP practice where I'm a patient, and I was looking at the scores. I was like, well, they're not that great. And then I was looking at, I was wondering whether that was the same in the previous quarter or the quarter before. And it's quite hard from this report to gauge whether, because it doesn't really tell you how that trend is changing over time. And so I think that just would be useful to maybe pick out, are there consistent trends? Because it's great doing this, but then I guess what we really want to see is, what impact does that have? Is this being taken on board? Are changes being made? So therefore then have a look at, because otherwise it's just sort of just a single snapshot. I think the trend over time is helpful.
Yeah, you want a scorecard, essentially, sort of giving us a tracking progression. Yeah, I wonder if that's something we could perhaps look at to see whether we could, over successive reports, see if we could give an indication of what the previous score was, and then what the current score was. Obviously, there are data issues with, maybe you're not asking the same people, for instance, but it could just be an additional snapshot or additional indicator of progress.
To the very kind of the larger issue, the survey has been redesigned for quarter 3 to capture more effectively primary care services and mental health services in the community. And that's something we're kind of really pleased of. And just based on initial numbers in quarter 3, it looks good. The report is also being redesigned to better capture that data. What I'm hopeful of, as it kind of becomes a thing and we welcome kind of critique and assessment from it, is that it captures multiple reports at the same time so we can identify those trends.
Excellent.
The trends that are easy to identify are kind of the overall macro picture, whereas individual GPs, we tend to rely on having to look back at the multiple reports just because it isn't ever really the same people.
No.
And it varies from quarter to quarter unless something sticks out to us dramatically. So if a GP is getting quite a lot of negative reviews, we're getting quite a lot of really positive reviews, we do kind of follow up with that over the following.
Yeah, that would catch your eye, wouldn't it?
Yeah.
Yeah. So I think maybe perhaps you mentioned that on the Health Watch Healing website, you can scroll back to find historical. Maybe there's a way of indexing on the website, perhaps what the previous score was, or
I think we should definitely take that into consideration.
Yeah, that may be the way to encapsulate what Councillor Conti's looking for there. Just on the first point, yeah, I do want to take a broader look at mental health. We've been wanting to do it for some time. One of the elements to this is that North West London themselves, through their reorganisation, they've got a mental health strategy that's come to their, I'm going to get the blooming acronym wrong now, their integrated care board. Thank you. I was going to get it wrong, and then Anna Marie rescued me. Yeah, so they've got something that's come to their integrated care board. I think it's important for us to see what they're planning, and then we can scrutinise it effectively. But I think it marries up to some of the elements that Kerry was speaking about earlier. So yeah, let's take that away and look at how quickly we can get something forward. And I've got Nahal.
Thank you. I think Councillor Conti makes such an important observation about that longitudinal view about what's happening in access. Last meeting, I had the paper on GP access, and unfortunately we didn't get to go through absolutely all of the detail, but a lot of the actions are coming from either feedback from what Healthwatch and these reports have said, or other engagement work that we have done, or the survey, the national survey that happens through Ipsos Mori, and then issues that we know. But it's really important to, sorry, a bit of a sore throat, but it's really important to play into the fact that there are seasonal variations, and we know, so this report was Q2 of last year. We know that the next report was when there were significant pressures with strep A and the children's illnesses, the COVID and all of the various viruses, and the pressure that was on general practice was significant. So it'll be really interesting to do that trend analysis, but also look at that seasonal variation and see what happens as well. And then all of the actions as I described in my last report, and whether over a period of time that does make a difference.
I think maybe there's an opportunity to marry up a couple of things here. We're going to have a look at how we can best document that progress on the Healthwatch website, or at least that's maybe just a recommendation from us to you, Daniel, and your team, to have a look at how you might be able to do that. It's not easy for the reasons you've outlined, but I'm also conscious of the fact that I robbed Nehar of some time in the last meeting. Yes, guilty. And we do need to also document some of that progress that is coming through that you've just referred to. And you were kind enough to say you would give us an update report in due course. I think that's one for the future work programme for us to look at. And I'm very open to input from colleagues in as to how that should be presented. And perhaps it could be presented alongside the next or in conjunction with the next set of Healthwatch reports, how we, once you've had an opportunity to redesign and bed in some of those changes that you like to make. I do think that's such a useful tool in measuring what is going on in our local communities, and I think it is important at this point for us to pay tribute to our GPs as well. They have been the bedrock of our, yes, your interest notwithstanding, Councillor Mataza and Councillor Conti, but in all seriousness, they were the bedrock of our first response during a time when lots of people were locked down through coronavirus. They stepped up in the vaccine rollout and vaccinations. And despite our gripes at getting through on the telephone at times, they do provide that very much well-loved link between our constituents and the health service. And I think it's really important. Yeah, Anachan, go on.
Clapping for the NHS as well, and supporting the front line and the ambulance on strikes and stuff.
Might take me into some territory that might be dangerous, Alan, but the broader point is very well made. Absolutely, that all of our health service colleagues have given us so much. So I think it's pertinent at this point if I ask Nehar to communicate the panel's real appreciation for all of our North West London NHS staff. If you could make sure that that's fed back from this panel to your staff and your teams, that'd be really brilliant.
Absolutely, will do. But we have to also recognise social care have been absolutely really important partner in that, and community transport, which I've said before as well.
Yeah, we've already talked about social care earlier in the evening, but yeah, and indeed my friends at ECT doing an excellent job, and Councillor Mataza is going to give a plug for something now. Go on, Councillor Mataza.
No, I just wanted to say thank you for recognising, especially Healthwatch Ealing, giving us feedback how we perform. And it's a part of our journey from clapping to slapping. So it's always.
Well, hopefully not the latter, Councillor Mataza. I don't think we're quite there yet. But look, thank you, Daniel. Really important information, very well presented. Really crystal clear. And I've completely forgotten about Mr. Cook. So we need to go to Mr. Cook. Sorry.
Okay, it's not a question, it's just an answer to something. In the report, you'll find that each practice has 8 categories, and the top line of each one is a score for that particular quarter. Underneath that is a year rolling. So you do get an idea of what happens throughout the year.
Just got to know where to look, Councillor Conte. There you are, you see. And he's been on this committee long enough to know that, probably. Excellent. So we have got some of that data. Maybe it's just about making it a bit more prominent. I don't know.
I think it can definitely be highlighted better in terms of over the 12-month period, and hopefully the new reports accomplish that goal.
So I think it's incumbent on us to give you more, to help promote the work that you do more, you know, for helping to try and find some more volunteers, helping to make sure that the work that you do is more widely read through Ealing. So perhaps there's a way that we can do that through the council's website and its communication channels. I don't know. I'm just spitballing here, but I think it's worthy of some more consideration. So I'll mention to my colleagues. But Daniel, thank you so much for that. Right, I've got one more item, which is to ask you to review and agree the work programme. It should be fairly straightforward because the next meeting is the last meeting of our municipal year. That happened fast. What we are going to do then is take a report on the work of the Health and Wellbeing Board. We do this quite regularly now. It's an opportunity for us to review the items that don't ordinarily come to this panel, because we mainly scrutinise rather than set the policy framework for health and social care. And we are going to take, as I mentioned earlier, the first of the annual Health of the Borough reports. It's a new initiative. I'm not quite sure how it's going to work or how successful it's going to be, but it should give us some of that information on where we are as a borough, what the council's priorities are, how everybody is performing, and give us an idea to feed into how we scope that going forward. And I will also need you to help me in what we will lay before that next meeting are some recommendations more broadly around social care and some of the things we are trying to look at, with a recognition that I think it's important, and it would be my view at the moment, that work reviewing social care continues, because we've only had a few meetings where we've been able to look at it, and I think it's worthy of deeper consideration. Certainly some of the elements that Erskag and other colleagues have brought up, and indeed some of the stuff we've heard tonight, I think from the Power Group is equally applicable into this area. I do need to tell you that, well, Councillor Steed and I have been slightly frustrated in our aim to do a sort of London-wide or even wider tour of various social care setups. It's been a bit challenging. What we have done is arrange some visits to some of our Ealing-based services. So we've got the TB outreach services and RISE, what you'll know, members will know as our drug and alcohol treatment service. We've circulated some details to panel members of those visits going to take place in the next month or so. If you can come along, that'd be great. And that will feed into some of our recommendations. So that's the work programme. The date of the next meeting is the 12th of April, and it is unfeasibly early for me to finish a health and social services scrutiny panel meeting, because you're going to be out here well before 10 o'clock, which must be some sort of record under my chairmanship. So thank you very much for your consideration. Thank you to everyone who's online.
Thank you, Chair.
Has helped. Thank you, Councillor Alexander.